Good noon, everyone. I'm Dr. Ana York Bondok from the Mu Sigma Phi Sorority Batch of 94, and I'm speaking in behalf of the Aging and Longevity Webinars team of the Mu Sigma Phi Sorority. We are live streaming today from the video conference room of the UP Manila Information Management Service. And our time right now is exactly 12 noon. We have a total of 915 registered participants. Wow, that's a lot from all over the Philippines and even some from abroad as well. So hello po to those who are tuning in from Tokyo, Singapore, New Zealand, Fiji, UAE, Qatar, and New Jersey. Wow. Oh, ma'am. So kahit malamig doon, I would like to report summer dito. So this webinar series runs every second and last Friday from January to November 2019, and we will be delivering interactive medical lectures by prominent specialists both here and abroad on common and much needed medical conditions in the geriatric population. Today's webinar was awarded 10 PMA CME units for doctors, 1 CPD unit for physicians and pharmacists, and 2 CPD units for nurses. So for today's webinar, we are honored and it's a privilege for us to have a distinguished alumna from the UP College of Medicine, class 1968, as our speaker. She completed her training in internal medicine, cardiology, and clinical pharmacology at the Philippine General Hospital, the Harvard Medical School, and the famous Massachusetts General Hospital. Doctora was the DSWD secretary from 2006 to 2010 and the DOH Secretary in 2010. She was also the past director of the Philippine Heart Center, the president of the Philippine College of Physicians, the Philippine Heart Association, and the Philippine Society of Hypertension. She is currently the senior policy advisor of the United Nations Population Fund and chair of the DOH National Implementation Team for the Reproductive Health Law. So ladies and gentlemen, we are very proud and extremely honored to welcome Madam Dr. Esperanza Cabral from the Mu Sigma Phi Sorority Batch 1986. 1986. 1968.
Sana 1986
Oh, nga, ako gusto ko. So, okay, Doktora, it's a privilege po.
Thank you and good afternoon. Our topic for this afternoon is hypertension in the elderly. I have nothing to disclose. Okay, first let us remind ourselves that approximately 25% of adults in the Philippines have high blood pressure. That comes to about 12.5 to 13 million Filipinos having blood pressures equal to or greater than 140 over 90 millimeters mercury. The prevalence of high blood pressure increases with age, such that by 60 years, 45% of Filipinos have high blood pressure, adult Filipinos I mean, and by 70 years, 55% have high blood pressure. As a matter of fact, in the United States Framingham study, high blood pressure was found to eventually develop in more than 90% of subjects with normal blood pressure at age 55. So hypertension in the elderly is important because older people are the fastest growing segment of the population. The prevalence of high blood pressure in this group is very high, and there are several issues that make managing hypertension in the elderly unique. One is that it is frequently a type of high blood pressure that we call systolic hypertension. Second, it is more likely to be present with other comorbidities. On the other hand, many clinical trials in hypertension have excluded these patients, particularly those who are 80 years and older. In addition, the elderly are more susceptible to certain adverse effects. So our discussion this afternoon will rest on defining hypertension in the elderly, the pathophysiology of hypertension in the elderly, preventing strokes and cardiovascular events by controlling high blood pressure, and the treatment of hypertension in the elderly. First, let us define the elderly. Most studies will define elderly as someone greater than 65 years. There are a few studies that will define elderly as starting with 60 years and going upwards. And the really old are those who are 80 years or over. When it comes to hypertension, the general definition of high blood pressure is a systolic blood pressure equal to or greater than 140 millimeters mercury, or a diastolic blood pressure equal to or greater than 90 millimeters mercury. In the younger population, the definition of hypertension usually refers to an elevated diastolic blood pressure. But in the elderly, it is known as systolic hypertension, which is defined as a systolic blood pressure greater than 140 over 90, a systolic blood pressure greater than 140 millimeters mercury and a diastolic blood pressure less than 90 millimeters mercury. Some of the characteristics of systolic hypertension are that it continues to rise with age, whereas the level of diastolic blood pressure levels off or decreases with age. Thus, systolic hypertension is the most common cause of hypertension in patients over 50 years, and 75% of hypertension in those over 65 years is systolic in nature. So after 50 years, systolic blood pressure is the much more important risk factor for cardiovascular events than diastolic blood pressure. And very often, systolic blood pressure is more poorly controlled than diastolic blood pressure. Okay, well, how do you develop hypertension in the elderly? Multiple changes occur in arteries with aging, including reduced elastin content and increases in non-distensible collagen and calcium that result in arterial stiffening. Age-associated arterial stiffening results in an increase in systolic blood pressure and a decrease in diastolic blood pressure. So flow-mediated arterial dilation declines with age. Older hypertensives are also characterized by increased plasma norepinephrine, low renin, and low aldosterone levels. However, many so-called normal aging changes in arterial structure and function are in fact blunted or absent in populations eating a good diet, low in sodium and low in calories, who engage in physical activity and have low rates of obesity. This is a graphic illustration of the pathophysiology of systolic hypertension compared to the pathophysiology of diastolic hypertension, where you see on the left-hand side of the slide the stroke volume, the appearance of the aorta and the resistance arterioles, as well as the flow or pressure in young arteries compared to older arteriosclerotic arteries with stiff vessels. What you see here is that in the younger arteries, there is a dilatation of the vessel during systole that produces a lower amount of flow. On the other hand, when this dilation rebounds, there is an incoming diastolic flow, which is absent in stiff vessels. So as people grow older, their mean arterial pressure goes up, the pulse pressure goes up, the diastolic blood pressure goes down, and the systolic blood pressure goes up. The effect on coronary heart disease rates is an increase in coronary heart disease mortality as a person ages and as the systolic blood pressure goes up. So here you see that if a patient has a systolic blood pressure of 180 millimeters mercury and the patient is old or very old, then the mortality rate from coronary heart disease is much higher compared to the person whose blood pressure is lower and whose age is also lower. There are joint influences of the systolic blood pressure and the pulse pressure on coronary heart disease. And this graph shows us that again, the coronary heart disease hazard ratio increases as the pulse pressure as well as the systolic blood pressure increase. The effect on stroke mortality is noted in this slide. And again, stroke mortality increases as systolic blood pressure as well as diastolic blood pressure increases, and the increase is greater as the age increases also. Now, the risk of adverse outcomes among elderly coronary artery disease patients by age and blood pressure is shown in this slide. And we can see what we know as a J curve of the risk of adverse outcomes as plotted against the diastolic and systolic blood pressure. The J curve is more pronounced with diastolic blood pressure. What we see here is there is a point where the diastolic blood pressure can be so low that the hazard ratio for coronary artery disease increases in much the same way as it does when the diastolic blood pressure is higher. With systolic blood pressures, on the other hand, the J curve is blunted, and the coronary artery disease hazard ratio is not so much related to the lowering of the blood pressure as it is in diastolic high blood pressure. So now we know that in the elderly, hypertension is the most frequent cardiovascular risk factor for patients with myocardial infarction, patients with strokes. But it is also a major risk factor in the elderly for patients with chronic heart failure, acute aortic syndrome, patients with atrial fibrillation, and other diseases. By controlling hypertension, many studies have shown that strokes and cardiovascular events can be prevented. And this slide shows us the reduction in systolic blood pressure also reduces major cardiovascular disease events. This composite of the effects of a 10 millimeter mercury reduction in systolic blood pressure on adverse effects shows us the same thing. There is a study called the Hypertension in the Very Elderly Trial, or HIVET, which shows us that among the very old, meaning 80 years or more, controlling the blood pressure will also still control cardiovascular events, in particular all strokes, stroke deaths, all-cause mortality, heart failure, and cardiovascular events. Two older trials on hypertension in the elderly also showed the same thing. One is called the SHEP, which is systolic hypertension in the elderly program, and the other one is SYSTUR, or systolic hypertension in Europe. And in these two trials, they also showed that fatal and non-fatal stroke, fatal and non-fatal heart failure, and combined fatal and non-fatal MI, coronary heart disease death, sudden deaths, were favorably affected by controlling the blood pressure. So, okay, the studies show that hypertension is good to treat even in the elderly. On a practical basis, how do we do that? We are guided by clinical practice guidelines that are put out by various organizations on treatment of hypertension in the elderly. And this is just an example of one of those clinical practice guidelines. There are three things I want you to take note. One is that all the clinical practice guidelines start with lifestyle modification as treatment for hypertension, whether it is in the elderly or not. Only after lifestyle modification, particularly in the lower levels of hypertension, only after lifestyle modification would we go to drug treatment. The second thing I want you to note is that nearly all antihypertensive agents will work to lower the blood pressure, but some of them are better than others when there are other comorbidities or compelling indications. The third thing to note is that majority of patients with real significant levels of hypertension will require two or more drugs to reach their treatment goals. What are those blood pressure goals? These are several clinical practice guidelines from several groups that show you the blood pressure goals for people aged less than 60, those between 60 and 79, and those greater than 80. What it shows that in general, the blood pressure goal is to bring it down to below 140 over 90, although in the very old, it can be liberalized to below 150 over 90. And the guidelines on BP threshold for drug treatment are levels above those blood pressure goals. As we were saying, lifestyle changes are to be implemented ahead of drug treatment. These include regular physical activity, sodium restriction, weight control, smoking cessation, avoidance of excessive alcohol intake. And in practical terms, this means reducing salt to less than 5 grams a day, and so forth and so on. We said that nearly all agents can be used in the elderly hypertensive, and that the choice of drugs is dictated by efficacy, tolerability, presence of specific comorbidities, and cost, and that in most individuals, more than one drug will be required. Okay, so to start with, you can use any antihypertensive agent. If the blood pressure is not controlled, you can go to a two-drug combination. If that is not controlled, the blood pressure is not controlled, you go to a three-drug combination. And we have to note that two renin-angiotensin system blockers, such as an angiotensin converting enzyme inhibitor and an angiotensin receptor blocker, should not be combined. Okay. To reiterate, the evidence is strong that lowering office systolic blood pressure to less than 140 is beneficial for all patient groups, including independent older patients. But that in the old and very old, independence, frailty, and comorbidities will influence our treatment decisions. We have to be aware that antihypertensive treatment-related side effects are important considerations in treating the elderly because they are very prone to electrolyte disturbances, renal dysfunction, and orthostatic BP decline when the blood pressure goes down too low. We already stated that our BP goal is to bring the blood pressure to less than 140 over 90. In the very old, bringing it down to less than 150 over 90 systolic, less than 150 systolic seems reasonable. And that we should also note that we must manage the other cardiovascular risks in our patients. In summary, hypertension in the elderly is very prevalent. It is a major treatable risk factor for cardiovascular disease. Typically, systolic blood pressure elevation with normal diastolic blood pressure is the kind of hypertension that they have. In the elderly, there are many comorbidities that make management a challenge, and that lifestyle modification is useful even with drug therapy. Because the elderly are prone to side effects, we should begin with a low drug dose and titrate the drugs slowly until we reach the blood pressure goal of less than 150 over 9, less than 150 millimeters mercury. Thank you very much. I think that's really all I have to say.
Thanks, Doctora, for the updates on the hypertension for the elderly. So, tingnan po natin kung ilan po yung mga nanonood sa atin today. And thank you, Doctora Cabral. It's a very interesting and comprehensive talk. So, ito po, we have 268 Facebook Live. We have 67 viewers po on the UP Manila live stream. And we have 52 viewers po on YouTube. So, panalo po si Facebook Live. And then we have 7 groups. Naniniwala ako sa Facebook eh. And we have 7 groups viewing from all over the Philippines. Siguro po, baka naman you'd like to share with me kung sino po yung 7 groups na yun. Later. Kasi I'm curious, saan sila and what are they doing and why are they watching? Because siguro they'd like to learn about hypertension, of course. So we would like to thank MSD or Merck Sharp and Dohme Philippines for the support for this webinar. So ngayon po, the floor is now open to questions from the audience. Just type in your questions at the Q&A chat box in the right lower corner of the live stream window, or type in your comments in YouTube Live, or send personal messages, i-DM nyo po, FB at Aging Webinars for the Facebook Live viewers. So we have 25 minutes for your Q&A. So padala nyo na po. Okay? So let's check. Meron na ho ba tayong question or ako na lang muna? Okay. Very striking po sa akin was that you said that yung target po natin is not 120. Kasi some people don't know that eh. Some doctors say, feeling nila 140, nagpapanik pa rin po sila, gano'n. And pinipilit po nila yung 120. So, this is something that needs to be clarified. So, pakiulit lang ho that the standard is not 120. Tapos, may nako-confuse pa ko. Kasi may bagong guidelines sa lumabas na 130 over 90 po, problema na yon. So, paki-clarify lang po. And I guess the approach to the elderly is different from the approach to younger patients.
Oh, so, precisely, okay. Anna. The guidelines...
Kasi meron pong mamimilit, hindi pa ko kayo 120, then third, fourth drugs na or whatever.
The guidelines that you're talking about refer to the garden variety hypertension.
Ayun na nga, dapat ilinaw yun
less than 60 years old. For those who are over 60 years, the guidelines are more liberal because now we said that these patients are generally more vulnerable to the side effects of the drugs. And if they get dizzy because they develop orthostatic hypotension and they fall, that is an even worse problem than having hypertension.
Baka may mahilo ko, then masaktan, mabalian pa.
Ganun nga. So it's fine that your blood pressure is 120 over 80. Pero ako ang feeling ko dyan is you need to bring the blood pressure down to approach that level, that perfect level of 120 over 80, as long as the patient is able to tolerate it. Because not everybody is going to tolerate 120 over 80. Some of them are going to have undesirable side effects from the drugs that you're
taking. Baka tatlo na yung iniinom nilang gamot para maging 120.
So baka hindi na nila kaya yung halaga nung gamot na ibinibigay mo sa kanila. Pagka-apat na yung pinapainom mo na antihypertensive, together with the other medicines for their other comorbidities.
Kasi ang dami namang kiniinom ng mga matatanda po.
I have patients who used to take at least 20 pills a day.
Oh my God.
Yeah.
So, ayan po. Ayan ho. So, I guess this is the question. And just like I asked, to clarify lang daw, 140/90 is the goal for the elderly. But for the non-geriatric population, the goal is 130/90.
Yes. Less than 140/90 and less than 130/90.
Ayun. So, alalahanin niyo yun, okay, pag 90 na ho yung pasyente, hindi ho this is not less, is more. So, may hangganan po. So, was there any latest research? This is from Delphine Soriano po. Was there any latest research on lifestyle modification as an effective management for hypertension?
Oh, there are well-established data from good researchers that tell us what lifestyle modifications do. For example, the data shows that if you reduce the salt in the diet to less than 5 grams per day, you can lower the diastolic blood pressure by 5 millimeters mercury from what it was in the start.
So, salt po.
Yeah, and there are other data that show you how much you can lower the blood pressure by going from obese to normal body weight. There are also data that show you how much the blood pressure will go down if you stop smoking. After a while, your blood pressure, just because you stop smoking, can go down anywhere from 7 to 10 millimeters mercury diastolic.
So it works.
Yes.
Po. And this is from Dr. Joey Canyal. Sis po natin to. That one slide on lifestyle modification recommendation was great. Actually, totoo yan kasi po, I am a cancer specialist po. So, meron po akong pasyente na nagkaroon na renal cancer. Malaking mama po. So, pinadala ko sa States kung siya na-opera. And then, tinanggal yung liver niya, and liver nodules and the kidney. So pagbalik ko sa Pilipinas, so he was also hypertensive. Siyempre, maraming kinakain, malaking mama, lots of stress po. He came back to the Philippines, cured po of his cancer. And then, ang payat-payat ho niya kasi na-opera siya.
Okay.
Tapos sinabi niya sa akin, Doktora, wala na rin ho akong hypertension. I was like, okay, good. But I don't think cancer po is the cure for hypertension. Basically, namayat po yung mama. So nawala po yung BP. But that is really true. So, eto po, are there any other treatment options other than taking antihypertensive medications? Siguro ayaw mo itong uminom ng gamot. And this is for 50 to 65-year-old age group.
Okay, we said that the first option is really lifestyle modification. Maintaining a proper body weight, not smoking, not drinking alcohol to excess. What else did we say? Physical activity, those things. Because if you do those, there is a possibility that you will not need drug treatment because they can really lower the blood pressure.
Depende po kung gaano takot kayo. Kasi kung hindi kayo masyadong takot, hindi ko magawin yung lifestyle nyo. So yun. At Doktora, ito lang yung point ko rin. Sa akin po, my answer to that is it depends on what's your BP. Kung nasa 190 na ho kayo, and it will take you 3 months ho to lose weight, or maybe even 6 months. I don't want to leave anyone naman ho at 190.
Well, the guidelines actually say that if your blood pressure is
exactly
160 or more, over 100, you start the medicines together with lifestyle treatment.
Yes.
Okay? Obvious naman yun.
Ayun naman. Marami mo kasing pinabola yung doktor. Hindi mo magpapapayat ako. 3 months na wala pa. So kaya yung talagang kailangan mag-start na. So ito, I guess that answers the question of Dr. Canyal. Sabi niya, meron silang family history in hypertension. Siya daw borderline. Should she start taking meds now or should I wait until lifestyle modification doesn't work anymore?
Yeah, if she's just a borderline hypertensive,
magpapayat na muna.
Start lifestyle changes muna.
Yes. Okay. Thank you also. May bati ho dito from Christine May Basense. I am watching with my friends. The topic is very interesting. Wow, salamat.
Salamat.
Yun na nga. Another thing po that I wanted to, is, for example po, just throw out lang po yung thoughts nyo kasi hindi nyo po masyadong nabanggit. Kung diabetic po, how would you start? Anong gusto nyong i-recommend na gamot? Let's say diabetic.
That's a very important question because very frequently yung high blood pressure may diabetes at yung may diabetes, merong high blood pressure. When you have them together, the risk for cardiovascular disease is even greater than if you have just one or the other. So it's very important that the blood pressure and the blood sugar are controlled. For diabetics, we generally start with either a calcium channel blocker or an renin-angiotensin blocker, because we know that these two classes of medicines do not have bad effects on the blood sugar. On the other hand, diuretics have hyperglycemic effect, as do the beta blockers in some instances. So when you're starting out, you need to choose a calcium channel blocker and or an renin-angiotensin blocker. But, okay, so dalawang gamot na yung binibigay mo, hindi pa rin kontrolado. Pwede ka pa rin gumamit ng diuretic or beta blocker. It doesn't mean to say that those are absolutely contraindicated in diabetic patients.
Pero hindi po sila yung first choice.
Hindi sila yung first choice. They are additional medicines just in case the blood
Hindi na ho
pressure is
nakayanan
not
ng
controlled.
first two.
Yes.
Would you suggest ho, kung talagang mataas? Kasi we all know there's now combination meds sa market.
Oh, yeah, they're very
Meron
good.
mo bang case na talagang dalawa na ho yung isa-start nyo na combination drug na
Yeah.
kaagad?
Yeah. For blood pressures na say greater than 170,
Yung mataas talaga
188,
po.
talagang combination.
Dalawa na
kaagad.
kaagad yung ibibigay nyo or yung
Yeah.
combination pill na po?
Oo, combination pills are very good. Actually, yun nga ang sinasabi nila is
Yung
if
compliance
you need
po.
to
Oo.
use 2 pills, use the combination pill.
So there
already.
is a situation po na you would start 2 drugs kaagad?
Yes.
Opo. But both low doses?
Yes.
Oo.
That's it. The advantage of using 2 drugs
Opo.
right away even is that you can give lower doses of
Of
one or
both
the other.
drugs. Opo. So yun po. Question dito. Nagbasa daw siya. Siya is Suarez Pancho. She read a book that once a person is vitamin D deficient, there will be health consequences including hypertension. She had a friend though who tried taking vitamin D plus calcium and his BP normalized.
Mhm.
Baka naman nag-diet siya along with the vitamin D and the calcium. Hindi mo naman sinabi yun siya.
But
Did you
it's
also
actually
do-
true that there
Opo.
are some little studies that show that if you take vitamin D or some version of vitamin D,
Opo.
the blood pressure can go down. There are some researches that show those.
Meron ho ba talagang vitamin D deficient? Eh, lakas ho na araw sa Pilipinas.
Oo nga eh. Nung araw, tanong ko din yan.
Opo.
Ba't naman ako magkaka-vitamin deficiency? Ang lakas naman ng
Sige
araw
po,
sa Pilipinas.
i-share niyo po yung thoughts.
But in fact, for people like us, we don't
Opo.
go out in the sun too often.
Siyempre ko, kasi baka mangailangan ako ng ultherapy.
Ayan na nga, okay? And so it's not true that we get enough vitamin C from the sun because we don't go out in the sun too often.
So dapat i-check rin po.
Ngayon, yung mga magsasaka, ganyan,
Opo.
mga mangingisda,
Meron silang vitamin D.
yung mga construction workers na nasa labas talaga at naaarawan, siguro hindi nga sila vitamin D deficient. Pero yung office workers, yung mga katulad natin na nasa loob ng building palagi, ayaw magpa-araw kasi ayaw umitim, o ayaw magpa-araw kasi baka magka-skin cancer or something like that. Kailangan i-check nyo yung vitamin D levels ninyo, and very often, it is lower than what you expect. And if it is, just go ahead and take
Meron
some
naman hong
vitamin D
supplements.
supplement. So,
Is there a limited time that any anti-hypertensive drug may be continuously taken? By Glenn Rushana. Naku, Glenn, bad news for life na to.
yeah.
Habang buhay ka. Kaya mahilig ang mga pharma dito. Pag na-diagnose ka na anti-hypertensive, you're captured for life.
Except, as you said,
Opo.
if they're really good at lifestyle change
unless you lose
and the
40
blood
pounds.
pressure goes down, you can try reducing the dose of the blood
Opo.
pressure medicine. Tapos kung konting-konti na lang, you can give them a drug holiday,
Opo.
see what
Tingnan niyo
happens.
po kung ano
Oo.
mangyayari.
Yeah.
Opo. So I guess if you combine lifestyle changes and you manage to be successful po, pwedeng mag-trial. And then, do you encourage the elderly to use herbal meds? And what should they be?
Okay. Para sa akin, if we are talking of value for money,
Opo.
the best value for money is with the pills that have been proven to work.
Oo nga naman, may nakasulat doon na
Oo.
no, they
Yeah,
are
kasi
not
minsan titignan mo,
efficacious.
lalo na
tapos
ngayon
yun.
dito sa Pilipinas, either libre na yung antihypertensive mo,
Opo.
or baba-baba na kasi may
Kasi may
senior
generics
discount,
pa po.
wala pang VAT, ganyan, tapos may generics pa. Kung minsan, hindi lang minsan, madalas, yung halaga ng herbal supplements
Mas mahal
ay
pa.
napakalaki kumpara dun sa halaga ng
Siyempre,
totoong
may
gamot.
marketing mo si
Oo,
Herbal.
yeah.
Meron pa sila celebrity endorser.
Marami.
Kailangan bayaran mo yun.
Oo.
So, ang advice niyo po is value for money is better to take the antihypertensive
Yes.
drugs. Opo. What can we do for elderly patients who come to the clinic with a BP of 190 systolic but they're completely asymptomatic?
Okay,
We
then
can
you
stop them
can,
from leaving the clinic. Yun.
you
Wag
can
palabasin na
reassure
ganun lang.
them that
Opo.
they'll be fine, but that they need to take their blood pressure medicines because they won't be fine for long if they don't do that.
Ma'am, question, and I heard this rin from people na mga 80. Sabi nila, nag-survive na daw sila to the age of 80 with a BP of like 160. Oh, meron pa sa akin, ano daw ang karapatan ko? Hindi naman ako umabot ng 80. Maswerte daw ako kung makakaabot ng ganun.
Well,
So, like, ano ba, 80 na daw sila? Why don't we leave them alone?
Okay.
That's mantra ko yun ang chewin ko.
Okay, I'm an advocate of patients' rights. Okay.
Oo po.
So they can do whatever they want to do.
Oo naman, ma'am. Pero marami sinabi, ma'am eh.
Our obligation is to tell them
Opo.
what is going to happen if they do A or they do B and what our recommendations are.
Opo.
But when it comes to deciding for themselves whether they will follow it or not, that is entirely up to the patient. But we have to make sure that they are informed so that they can make informed choices.
Siguro po, I guess they just want to be reassured. Meron pa po bang point of treating an elderly person with hypertension? Definitely meron. Kasi po bababa yung risk nila ng stroke.
Yeah, pero in that case, for example, the 80-year-old and the
Opo.
blood pressure doesn't go above 160,
Opo.
pa-lifestyle change mo na lang siya muna, di ba?
Opo.
And then
Maybe he
later
wants to
on,
exercise, maglakad na naman.
konti. Kung
Kung
hindi
masyado
talaga
siyang
tumataas
palaban.
sa 160 at ayaw niyang uminom ng gamot, okay na lang sa akin yun. Oo. Pero kung 230, ibang usapan na yun.
Hindi, ER ang tawag ko doon. Hindi lifestyle change. Emergency room ang tawag ko doon. So, siguro naman, I guess, yung magandang pakiusap din po and explanation po of the facts is very important.
And that
Pati
is the
sa
only thing that
kamag-anakan.
we do, is to tell them what they have, what are the consequences if they don't do anything about it, and what our recommendations are.
So may question po dito from Christine again. Significant po ba yung side effects sa kidney pag long-term na po yung maintenance?
Okay.
Is this like a good side effect question or a bad side effect? Ano kasi kung matagal kayo maka-maintenance at maganda po yung hypertension nyo, di wala kayong sakit sa bato. So that's a good side effect question. I don't get the question po.
Okay, unang-una, yung side effects ng gamot ay hindi galing sa gamot mismo because none of these medicines actually cause kidney disease.
Wala rin nga ako kung alam eh.
It
Kaya
is
hindi
the
ko alam yung
improper use of the medicines that can do it. For example, if the blood pressure is too low, then you can get
baka mag-kidney failure din mo kayo.
correct, acute tubular necrosis or shock or something, and it will destroy your kidney. But if it is used properly, then there is no harm in that. On the other hand, if you do not control your blood pressure, then you will most likely go on to kidney failure, which is in our data the second highest cause of dialysis in the country is uncontrolled hypertension.
Yes, mabuti nga ako tinanong yun kasi studies have shown po that diabetes is the first and hypertension is the second. So I guess the question is, may effect sa kidney. Pag hindi nyo kinuha yung maintenance nyo, yun yan ang makikita nyo.
Yun ang makikita, effect sa kidney.
How about po, this question naman po, Andre Garcia, the question, the patient with DM and hypertension, how about if the patient is already undergoing hemodialysis? Mas lalong dapat.
Na tumataas ang blood pressure.
Opo.
Yeah, kailangan pa rin yan ng treatment.
Oo. Hemodialysis po is not the treatment for hypertension. So,
No,
it does
no.
not follow. So, baka naman po daw, there's a question po, baka naman daw po naninervous yung mga tao. So, they got white coat hypertension.
Sure.
Immediately po ba, iti-treat nyo na si 160 over 100?
No. If you look at the practice guidelines for those levels, actually, they tell you na you need to verify that these people have high blood pressure by taking their blood pressures at least twice on different occasions. Hindi yung pag nakita mo na 150 or 160, even 160, right at that moment, bibigyan mo na ng gamot. Una nga, sinabi natin, lifestyle modification muna. Tapos pababalikin mo, pag kinuha mo yung blood pressure, ganun pa rin. And then you start to consider giving drug
mag-usap na
treatment.
ho kayo. The question is about clonidine. What is the best route for taking clonidine as an initial medication for a hypertensive? Sublingual or per oral? Parang hindi ako nagsistart with clonidine unless extremely high.
Hindi na tayo nag-uumpisa ng chronic treatment for
Parang in the
hypertension
emergency situation po
with
ito.
clonidine. In some places, okay, kasi ano na rin yan wala na sa moda yung sublingual clonidine ngayon. Although in some places, meron pa rin na pagka masyadong mataas yung blood pressure,
kasi I'm an
nilalagay
ICU
nila.
physician, that's the only time that I would use
But the
clonidine
studies
po.
actually show that whether you give it sublingual or whether you give it orally, the effect on the blood pressure, the time is the same. No, the same. Yeah.
So, meron pa po dito but we cannot see it. So, my question po, for hypertensive Black populations, baka naman po, konting Black expats sa Pilipinas. Are there any anti-hypertensive? Baka naman po kasi may worldwide. So, sige. Are there any hypertensives that we should refrain from giving?
Yeah. Usually, the renin-angiotensin system blockers don't work as well in the Black population as they do in the Caucasian population.
And for you to be politically correct, yung ginagamit po namin dati sa US is African American. FYI lang. Okay? If the BP is higher than borderline, tinanong na po ito. If the BP is higher, what is the best type of anti-hypertensive drug as first line of defense in our newly diagnosed cases? Again, it depends po dun sa sa profile ng patient. Ma'am, kung men versus women, yun na lang ang tanong ko. Halimbawa po, ladies versus guys, may iba po ba kayong it's the same, no sex difference.
Pareho yung blood pressure.
You would choose the same po.
Yes.
How about what for those who are extremely nervous about side effects po, yung talagang nininervous po na patient, meron po ba kayong i-recommendang talagang not so high naman, pero parang ang concern po niya is talagang nininervous po siya sa side effects? What would you start naman po?
I think I will start by reassuring them that even as we talk of side effects and we say lahat ng gamot ay may side effect, yung mga side effects na makikita mo sa antihypertensives when used properly, halos wala. Okay? For example, diuretics. Natakot magbigay ng diuretics yung mga iba kasi bumababa yung potassium,
kailangan monitor,
etc. Pero pag ang ginamit mo yung tamang dose, halos walang ganun.
So it's the right dosage.
Yeah.
The right dosage po yung
Ngayon, kung it's an allergic reaction, hindi naman natin masasabi kung sino ang magkakaroon ng allergy. So, pag lang nainom mo na yung gamot, tapos nagka-allergy ka, tsaka mo lang malalaman.
Ma'am, how about kung cost po yung concern? Let's say talagang walang-wala ho si patient, pero let's say 180. Ano kung may start niyo naman? Baka beta blocker, ma'am, kasi mura lang.
180 ang blood pressure?
Baka naman masyado mahina naman si beta blocker.
Combination na yan.
So dapat po, or let's say somebody who talaga who's hirap po sa, and that you might, and you're worried na baka they will not continue. Baka 2 months lang ho sila. But you'd like them to to get the benefits po.
Yes.
What would you suggest? Baka diuretics, ma'am.
Diuretics and beta blockers have the cheapest generic brands.
Ayun na nga ho.
Oo.
Kasi yun ang alam ko po eh.
Yes. But ngayon marami na rin generics, yung mga renin-angiotensin system blockers.
So explore the generic,
Explore.
the costing.
Yeah,
Opo.
kasi with high blood pressure, it's so easy to know if it is having an effect or not. Kasi syempre, lahat tayo may agam-agam na, baka yung generic hindi umuubra.
So pwede
Diba?
naman matest.
Oo,
Yes.
pero ang dali-dali i-test
kung
nun for blood
bumababa,
pressure.
that means it's working. Kung hindi
Yeah.
bumababa, then not working.
It's so easy. So you test it, and if your blood pressure is not going down, then you go to something else.
Okay. Would you suggest po if the blood pressure is not going down to change the meds or to shift po to branded? I know this is a medyo political question.
You can do either.
Opo.
You can do either. You can change the brand of the medicine, or you can change the class of the medicine that you
Opo.
are.
So those are two options
Yes.
po ngayon. Change the brand or change the kind.
class.
Opo, change the class. Ayun po. So, an elderly 80-year-old has been taking beta blockers for more than 20 years. Should the medication be changed? Why? Siguro ang tanong, ang sagot mo dun eh. Kung okay naman siya for 20 years, bakit mo
the
kakalkalin
advice
yung...
is, yes, if the medicine is effective
Opo, live
and
well enough alone.
well tolerated, even if the patient is 80 years old, just continue with the medicine.
Kasi baka may mangyari pa ho, and then you'll be blamed by the relatives. Very important issue. Yung mga relatives din ho.
Very important.
Oo, kasi syempre, nabuhay nga si Lola ng 80, then pinakailaman mo, then nagkagulo-gulo po, and then may mga electrolytes, whatever, nalagay pa ho sa ospital. So, ikakalat po nila dun sa corridor kasi pinalitan yung gamot. Oh my God, you can be sure papalitan ka na next. 80 years old, alam mo, that's really difficult when you're dealing with elderly persons po. Kasi they are also independent, but meron din yung family issues na ano. If you're an 80-year-old po with a pacemaker and controlled BP, does anti-hypertension medicines, dapat pa bang bigyan?
Hindi, control yung blood pressure eh. Di wala. If the patient is on blood pressure medicines,
Huwag mo nang
maintain lang.
Oo, i-maintain.
If the patient is not on blood pressure medicines and the blood pressure is normal, there is no need to give any antihypertensive.
Alam mo, Mama, this is what I see all the time when I was in the States and even here. May matanda ako, mapapasok sa hospital. Let's say, napulmonya ako, ano? And then, parang for some reason po, hindi masyadong na-history, then hindi ho na-continue yung anti-hypertension. Siyempre, bawal hong iminom ng gamot galing sa bahay. Dun sa ospital, di ba? So, kulang naman ho yung history natin. So, siyempre yung matanda po, maybe couldn't remember everything. So, nasulat ho dun sa orders, kulang ho yung gamot. So, after 3 days po, na-cure na po si pneumonia. Next thing we know, hypertensive na po yung tao kasi syempre she's not taking the maintenance. So, ang takeaway ko po dito is when people go into the hospital, please be very complete po kung anong kinukuha nila.
Correct.
Tapos kailangan ho, yun ang dapat i-continue, ano po ma'am. Kasi otherwise, you'll get a new problem of hypertension.
Right.
Ako, ang solusyon ko po dun, dali na lang po lahat ng gamot, i-examine dun sa bedside.
Yeah, many hospitals will allow the patients to bring their home medicines, but give it to the nurse so that the nurse is the one who gives it to you.
Yun yung solution po doon. So, question po dito, meron kong personal question, haba pa ho. There's a brother po who is athletic, 49 years old, no vices or any other habits, with a family history. He used to jog or exercise, but he's working in Saudi. Oh, okay. His BP is still on 140 to 150 over 90. He is presently working as a staff in Saudi. What would you recommend for him? Athletic guy po, 49, with a history of hypertension. Ang BP niya is 140. Oh, so borderline po si BP. Bata pa to eh. 140 is not borderline. 140 is high. So he should be falling under the 130 over 90, di ba, ma'am? So ano pong recommendation sa kanya?
Okay, if he's living a healthy lifestyle.
Oo, parang athletic ma'am eh.
Yeah, he can get started on
Oo, dapat
medicine.
mag-start na. Kasi I'm presuming he's also not overweight. Opo. Mataas yun. Okay, so dapat mag-start. Would you suggest amlodipine use in diabetics?
Yes.
Kasi nag-concern po daw siya that amlodipine will result in proteinuria.
Not really.
Parang hindi ko narinig yun.
Yeah.
Opo. So, pwede po. Amlodipine is good for diabetics.
Yes.
Okay.
It's a good medicine
para
for those
clear
who can
lang daw.
tolerate it.
So it's safe to say that as a motivation to the patients that they could look forward to stopping antihypertensive medications if they are diligent taking the medicines in combination with the lifestyle changes needed.
Yes, there is a potential
Oo
to
naman,
do that.
ma'am.
Yeah.
Lalo na kung grabe kung, like, for example, they're extremely obese. Talagang may
Correct.
chance po
Oo.
sila.
Oo.
Ang kung talagang maganda na yung lifestyle nila, ay napakapayat na po nila at wala nang imo-modify, gamot na po yun. That's what I said, that's genetics na po.
Yes.
Yun. Pero, if you're really super malaking tao and you really karirin mo talaga yung health mo, it is possible. Is it advisable to give antihypertensives by sublingual mode in a hypertensive crisis for those in public health?
Well, if you have nothing else to
Wala
give.
na nga po yun
Yeah. But if you are in crisis, you should be in a hospital.
Talaga. And yung hospital naman ho, may gamot naman.
Opo.
So siguro ang worry lang niya is, for example, nandun ho siya sa field, then naka-BP po siya ng 230, may dala lang po siyang sublingual. Opo. Pwede na rin. Nobody can question you if you're in an island with a BP monitor of 230. Wala na ho. Okay. So, is it true that iron supplements increase BP?
No.
Parang wala rin ho ako narinig na gano'n.
Pero alam mo, common yan.
Opo.
Common, layman's urban legend or something. That pag anemic ako kaya mababa yung blood pressure ko. So the vice versa. On the other hand, pagka uminom ka ng para sa anemia or iron supplements, tataas yung blood pressure mo. Hindi po totoo yun.
Okay. Mama, this is my personal question. Kasi may mga tao pong mababa yung BP. Like, wala naman hong iniinom. Is that an issue?
It can be.
Kasi ako personally, I existed like 80 over 60 for many years.
If you have a blood pressure like that, but you're absolutely asymptomatic, very active, don't do anything to your blood pressure. It's just your normal.
One question lang, and this is something I also wanted to ask a hypertensive expert for many years. Does it matter where you're coming from? For example po, you are 190 and then you got to be 160. Di ba okay na yun? Samantalang if...
That's better than not going to 160.
Tapos for example po, ikaw you've always been 120 or 90. And then umakyat po to 130. So 130 pa lang may hilo ka ni. So, and is that... Kasi I have patients po na, yun nga, 80 over 60, then bigla pong nag-130, nahihilo na po sila sa 130. And they really don't feel, nafe-feel na po nila. So basically, is there a case na talagang 130 is already hypertensive for a person?
It's not necessarily hypertensive in the sense that if you do not treat it, you are going to get adverse reactions na important. But as you said, because you're not used to that kind of blood pressure, you can feel things.
Parang may pakiwari na po silang hindi na po
Very often, however, with time, you can tolerate it and you don't need to treat the blood pressure.
So it's not automatic na 130, dapat bumalik sila sa 80. Ganun po. With time po, mag-adjust din po sila. And 130
is still okay.
Unless grabe ho yung kanilang cardiac profile. And then, dapat i-treat na po. Why are people fixated on clonidine? Doktora, we use clonidine pero emergency lang. Like 180 and higher. Is this okay? And we check the BP every 15 minutes. And then, ba't hindi nyo padala sa ER ito? And then, if walang nangyari, we give the second dose up. Sandali na nga. Also, a good question before, ito na tinutuldok yung 180 as an emergency. It's true naman that 180 can be not an emergency. For some people have been existing as 180 all the time. So, ba't nyo inaatake ng clonidine ito? Ba't nyo tanungin yung tao kung ilang, kung 180 na siya for 10 years?
Tama.
So, they do not be fixated. Yung history po ng tao is important. And we might have time to bring the 180
Correct.
to the hospital to talk to said person quietly. Kasi pag nagpapanik tayo sa 180, baka
Lalong
atakin si
tataas.
180. Kasi, 180 can be normal for persons, but of course, hindi po natin iiwanan naman sa 180.
Hindi naman normal kung hindi
Opo, but they exist
matagal na siyang may ganun.
parang matagal na po siyang gano'n. So, unless they are showing symptoms po na yung mata po nila ay iba na, or they're about to impending stroke na po.
Correct.
Oo. Ako, ang suggestion ko po is bring them to the hospital. When is the best time? Ay, ito maganda ito, doktora, and I'm so curious. When is the best time of the day to monitor your BP?
You can monitor it anytime, but you should monitor it at around the same time every day.
So consistency
po. Consistency. If you want to do it in the morning, do it in the morning. If in the evening, do it in the evening. Or both.
Ayun na. Both. And so this is the last question. Sorry. Yun na po yun. Ang dami na akong tinanong. Super dami. So this is the last question because of time constraints. So we'd like to thank everyone who asked the questions. And once again, it's a huge honor. Talagang sobrang honor to meet a medical living legend. Ay, totoo yan, ma'am. Kayo po ang idol ko. For Dr. Esperanza Cabral for enlightening us with your answers. Ang dami ko pa kung gustong itanong, including paano kayo naging director ng Heart Center. Pero I guess ibang araw po yan. Kasi we were taken up all by hypertension. So I guess the things that we picked up po, number one po, hypertension in the elderly should be addressed. No matter how elderly that person is.
Yes.
And whether or not you would choose to take the meds, at least nag-usap po kayo. Ano po? And then number two is 140/90 seems to be a key number for us, no? Yun po talaga yung alert at yun din po yung what we should strive to. And thirdly, again, I guess this is really nice also, which we picked up po, is that lifestyle modification is something to be explored po talaga.
Correct.
Oo, huwag niyong pabayaan na puro gamot lang ang atake.
Tama.
Oo, marami pa rin pong possible. So again, we'd like to thank Dr. Esperanza Cabral for taking time out of her busy schedule. MSD also, thank you for joining us. And have a great weekend.
Thank you.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Phi Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST-ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. We would like to thank our sponsor for today's webinar, Merck Sharp and Dom Philippines. To receive your certificates of attendance, kindly answer the evaluation form by visiting the link on your screen within 2 days. The certificates will be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at YouTube at Aging Webinars channel. Please join us again on our upcoming webinar as seen on your screen. We are also announcing the launch of the OB Pearls book. Get your copies now. We would also like to invite you to attend the UP Med webinars every Wednesdays and the Lenten webinar series.